Thank you for the kind invitation. My name is Didi Fabian, Ido Didi Fabian. I have two affiliations. One is to Sheba Medical Center, just outside Tel Aviv in Israel. And the second is to the ICH, the International Center of Eye Health at the London School of Hygiene and Tropical Medicine, London, UK. And I will speak today on the role of online educational international tumor boards in order to optimize the diagnosis and treatment of patients with retinoblastoma. And I will use the example of the RBNet, the retinoblastoma network, which I'm in charge of, and specifically a project I founded in early 2020 called the RBNet MDT project. MDT stands for Multidisciplinary Team Meeting. Now, tumor boards are multidisciplinary team meetings which are used mostly in cases of cancer patients. The idea is to have a multidisciplinary discussion together with various specialists, including surgeons, pathologists, radiologists, sometimes social workers, nurses, and others. In the NHS in the UK, for example, it's obligatory to have the multidisciplinary team meeting and for all participants to sign a summary form. Otherwise, the patient is not allowed to be given treatment. Now, MDTs were found efficient for various cancer types. For example, in breast cancer, it was found that multidisciplinary team meetings resulted in revision of imaging and subsequently in treatment for many cases. There are, of course, plenty more examples in the literature. From the global retinoblastoma studies, we know that retinoblastoma is diagnosed at a late stage with more advanced disease and that there are less familial cases, most probably because these children do not survive. They simply do not make it to childbearing age. In many of these countries, mainly in Africa, MDTs are not regularly performed. This is taken from a study that was published in Ophthalmology in 2021, and it's a collaboration between colleagues from St. Jude in Memphis, Tennessee, in the US, North America, and RB specialists from King Hussein Hospital in Jordan, in West Asia. And specifically, this study investigated the impact of MDTs on survival of retinoblastoma in Jordan. So doctors from St. Jude linked with colleagues from King Hussein, and they performed via telemedicine joint meetings. In the graph, which is taken from the paper, you can clearly see that the MDTs resulted in reduction in number of deaths, so improved survival, and increase in the rate of eye salvage, so less, the opposite is enucleation, so less cases of enucleation as primary treatment. If you wondered how come patient outcome improved so drastically, so here's a possible explanation. In front of you are two graphs. This is also taken from their paper, their manuscript. The dotted line represents the learning curve of the local doctors, and the complete line, the patient outcome. And you can see on the left that without a twinning program, for example, between St. Jude and King Hussein Hospital, a patient outcome improves slowly in a linear correlation as the caregivers perform better. On the right side, on the contrary, the beneficial outcomes straight away from the very beginning are a result of sharing of knowledge by experts from St. Jude. This table also taken from that manuscript. So in the beginning, over 50% of the consultations, okay, in the early phase, 2003 to 2007, included recommendations to change the treatment plan. But as time went by, these decreased significantly. So in the second phase, 2008 to 2012, only 21% of the consultations included recommendations of change of treatment or change of management. And in the late phase, 2013 to 2019, just before the paper was published, it went down to 5% only. So we know that in low and middle income countries, retinoblastoma is more advanced, and we understand the impact of such twinning programs and the importance of telemedicine, and that MDTs, multidisciplinary team meetings, have a beneficial impact on patient outcome. How does one connect the dots? So in early 2020, I've created, together with good colleagues from the London School of Hygiene and Tropical Medicine, Marcia Zondervan, Nick Atsbury, and others, and many good friends from across the world, the RBNet MDT project. This project evolved since, but originally included national-based meetings. For example, the two RB centers in Uganda, one in Barara in far west Uganda, and the second in the capital in Kampala. But this is just one example. I'll show you in the following slide. A meeting lasts about an hour, usually not longer, and the local teams present a few challenging cases, usually between 2 and 4 cases. We invite an international team of experts to discuss the cases. The panel usually includes a pediatric oncologist and an ophthalmologist. That's usually the core team, but occasionally we also invite other subspecialties. Here's an example of the national tumor board that was done in Uganda. Various colleagues. So we have an ophthalmologist from the USA, that's Andrew Stacy. And we have a pediatric oncologist from Spain, that's Guillermo Chantada. He's the president of SIOP. We have an ophthalmologist from the UK, so that's Keith Waddle and Nick Atsbury. Keith is actually from Uganda, but he's originally from the UK. We have others on the team, so from India and Indonesia, etc. We have a dedicated website with now over 700 members from many, many countries. You can all link to this, connect to this website and register free and participate in such MDT meetings. Until now, we've had more than 200 meetings. I think it's near 300. You can see that members are from various countries, not only in Africa. We started in Africa, and that was the main focus, but we now have a very good team that is working with Indonesian teams. We've had meetings with Iran, with Pakistan, and with many other countries. This is just a glimpse, an up-to-date meetings taken from the website now in September and October 2024. You see that we have a meeting. We had a meeting with AMCC. We've had a meeting with the South African teams, and we're planning next month to have the first All-Africa RBNet MDT meeting, including all the teams in Africa, whoever's interested to join. AMCC, the Alliance Mondiale contre le Cancer, is a French NGO, a non-governmental organization led by Laurence Desjardins, who ran the oncology team in Paris. They use our platform, and they have a meeting every couple of weeks, in contrast to our meetings, which usually occur once every month, 2 or 3 months. Their meetings are aimed mainly to Francophone African countries. One of the main differences between their meetings and ours is that they usually deal with active cases that require immediate consultation, whereas our meetings, if it's once every 3 months, it's more academic, so to learn from a case retrospectively. Here's an example from, it's a recording of a meeting done with an international panel and Malawian teams.
Yes, exactly.
Not after
I think in my short experience, I've seen two such patients that present with a shrinkage of the eyeball in I think.
Oh, I see. Yes.
Yeah. So
you have the physical eye. Can give them
exactly.
That's probably what's going on here. Is the physical eye?
So the
with the necrotic, yeah, absolutely.
Yeah.
Physical eye is down the road. I think Ashwin is right. It's usually a down the line finding. So If Dr. Amos has seen that, that's probably a retinoblastoma that has been there for quite some time.
All this is my point about retinoblastoma masquerade. The child was delayed because something completely different appeared to be the diagnosis. As I say, put top of your list of any kid's bad eyes, put top of your list, there's an RB hiding inside. We've burnt our fingers and lost some kids through making this mistake, and many, many other people have in our country as well, in Uganda.
Well, even for the opposite eye that did not have the corneal edema, if it's a group E, the chance of keeping that eye group E with systemic chemotherapy is fairly slim. So it's going to be a challenge, both eyes. So I think your plan with what you have available, your goal is, same as our goal, saving the child's life. If you don't have intraarterial chemotherapy, then enucleation is probably your next best alternative.
Yeah, so currently in Africa, from what I know, IAC intraarterial is available in Egypt, South Africa, and Ghana. We just started in Ghana, in Accra, a few months ago, and it's private. It costs a lot. So that was a brief part of the MDT with Malawi, with Carol Shields and Ashwin Reddy and Keith Waddle and others. And here's an example of an MDT meeting taken outside Africa with Indonesian teams. We have here Guillermo Chantada and Petra Ketteler. Petra is the main moderator for these meetings.
So just, I totally agree with what Petra and Didi has said. We would have combined orbital radiotherapy involving the chiasm. But now after 12 cycles, I think you probably got rid of CNS relapse because you're probably not going, if it happens, it should happen relatively early.
We treat them first with chemotherapy, and then after the tumor become smaller, we considered to perform enucleation or others.
Metastasis in the CNS, then I would also suggest palliative care. If you have the option for a curative attempt, then your question was whether to enucleate. I would enucleate as soon as possible.
And then continue 18 cycles of standard dose chemotherapy. The tumor in the right eye become bigger. From REDCAM, the retinoblastoma become group E. And then we plan to do enucleation. But the parents refused and it did not come to our hospital for 7 months.
That's right, Didi. That's right. We've published this protocol in ophthalmology. If somebody wants to refer to that, orbital retinoblastoma, we've compared two different protocols, and published our results from our center.
So again, we had there also Bhavna Chawla and Ashwin Reddy. The meeting lasts, as I've mentioned, about an hour, and you got here just about 2 or 3 minutes. This year, we started something else. We started with specialized MDT meetings focusing on pathology of retinoblastoma and imaging of retinoblastoma as separate meetings. This is just one example of a clinical pathological correlation meeting with Kenyan teams and specialists from across the world. So the specialists, for example, we have here Anita Shah from Singapore. She's an ocular pathologist, and we discussed the clinical pathological correlation here. That was in February of 2024. And here's, I wasn't sure this is a video, so I'll show you. It's part of the meeting we had of a clinical pathological correlation MDT that was done in April 2024 with Indian team.
Just to tell you that the optic nerve was normal, so it was not infiltrated by tumor. And in the surrounding choroid, you can see some retinal pigment epithelial proliferation, which is also expected in post-chemotherapy.
Okay. Imaging RBNet MDT meetings. So this is an example of a meeting that was held in April of this year, including imaging experts from the ERA group, which is the European Retinoblastoma Imaging Consortium. So Selma Siren, she's from here. She's originally from Germany, but currently in Switzerland. Herve Bries from Paris and Pim de Graaf from the Netherlands. And here's an example from clinical radiological correlation.
At the time of examination under anesthesia, that's what we went ahead and did. So the bone marrow aspirate, it was negative for any atypical cells, and the CSF cytology also was negative, indicating that there was no bone marrow or CSF metastasis in this child. And as I mentioned, the right eye was absolutely normal, and the left eye, there was no fundus view at all due to total hyphema. So the next step is always imaging. And in retinoblastoma, we always prefer to do MRI orbits rather than CT imaging because we want to minimize the radiation exposure in the child. And that's what we went ahead and did. Now, Dr. Ravi Verma will take over and tell us a little bit about imaging in retinoblastoma. Dr. Ravi Verma, over to you.
Since there's the first MDT meeting of retinoblastoma net, we thought we'll start with a small capsule on imaging in retinoblastoma.
Okay, so again, a very brief part of the MDT, and you can see how we include the clinician's view, so Swati Kaliki here, and the radiologist. On the panel, we also have, as I've showed you, a radiologist and clinicians, so ophthalmologist and a pediatric oncologist.
At the time of
Here's an example of a full MDT. This was the first meeting that was done in June, so 3 months back. We had two cases, one presented by Ashwin Reddy and his team. So on his team, there was a pathologist, a radiologist, and a pediatric oncologist. And the second case was presented by my team with specialists from the same disciplines. And on the panel, we had Petra Kettler and other specialists, so radiologists, pathologists, and ophthalmologists. What's very interesting here.
Thank you very much for the introduction, and good morning, good evening, good afternoon to everybody worldwide. A big thank you to Didi for organizing this meeting and the team of the RBNet MDT in London. I'd like to introduce the panel. We have from radiology, Hervé Bries from Paris and Selma Sirin from Zurich. And also Pim de Graaf from Amsterdam. I think he'll join in a minute.
Excellent. Well, thanks very much again for the invitation to speak, and thank you to my colleagues. Just to remind you, so I'm Ashwin Reddy. I lead the retinoblastoma service in London. I'm an ophthalmologist. We've got Ulrika Lobel, who's our neuroradiologist, Victoria Bryant, who's our pathologist, and we hope Tanzina Chowdhury will be with us at the end to give us the pediatric oncology input. So this is an 18-month-old girl. Uli, if you want to comment.
No problem. So the first image is the axial T2 weighted imaging. You can see the tumor there in the left globe. The globe is also expanded, and there's retinal detachment with layering and fluid.
So we elected to perform an enucleation. We had a discussion at the MDT about the length, the amount of posterior laminar optic nerve invasion, and this is performed by my colleague Mandeep Sagu. And we knew that a long piece of optic nerve needed to be taken. So he cut the optic nerve with enucleation scissors for the longest length. And he actually went in again and took another stump, a bit of optic nerve as well. And he placed an acrylic implant 20 millimeters in the orbit. So now we go to Victoria Bryant, Dr. Victoria Bryant, who'll talk to us about the pathology.
Hello, everyone. So we're going to show you lots of pathology. So in this first slide, you can see the eye with the upper and the lower culottes removed. You can see that the posterior segment is almost completely filled with tumour. And if you look closely, you can see little flecks of calcium throughout that tumour. So in the midsection of the globe, the optic nerve resection margin is inked in green, and we actually measured 6 millimeters of optic nerve received with this eye. And then to the far side of the slide, you can see the optic nerve stump that we received, and that was 3 millimeters in thickness. If you go to the next slide, please, Ashwin. So this is just a low power view of the tumor.
Okay, so again, just a brief part of the meeting, which, as I've mentioned, included two cases that were presented, one by the team from the UK and the second by my team. So 1 hour, 30 minutes for each case, about 15 minutes presentation by the various specialists, and then it was followed by a very vivid discussion. Now, since 2022, we have an annual RBNet Challenges meeting with rapid fire case presentations given by colleagues from across the world. So we had 2022, 2023, and this November, so in about 2 months, just less than 2 months, I think it's November 22nd, and you're all invited. We have the RBNet Challenges. So that is not national, it's global, I would say. So usually we have 5 case presentations, rapid fire case presentations with the attendees, with the audience, who are all RB experts from across the world that can use the poll feature of Zoom to vote and suggest for each case separately what's the best next step. I did not include a video here, but again, you're all invited to join the next meeting. If you're not sure about the link, so please send me an email or a text message or through Tatiana, and I'll send you the link for registration, which is free, of course. This year, because we started with the kind of real MDTs, including all the subspecialties, we'll have the rapid fire case presentations. If I remember by heart correctly, then we have presenters from France, from Thailand, from Argentina, from Tanzania, and from the United States. Those are the 5 rapid fire case presentations. And then we have a real MDT with a case presented by the team from Essen, Germany, led by pediatric oncologist Petra Ketteler and her team. Of course, we have the parallel team on the panel with the pediatric oncologist, ophthalmologist, radiologist, and pathologist. The case will be, it's a very interesting case. It's a case of NMIC amplification retinoblastoma. This was discovered some years back by Brenda Gali and her team, and that a presentation will be followed by a keynote lecture by Brenda Gali herself. So again, you're all invited, November 22nd. And these are the presenters. So we have Petra and her team from Essen, and we have the various presenters, as I've mentioned, from Thailand, Argentina, France, the US, and Tanzania. We have Brenda Gali, and this is the panel, and I will be moderating. So in conclusion, this was a brief 20+ minutes presentation on the importance of multidisciplinary team meetings, tumor boards, in fact, for cancer patients in general, and retinoblastoma in specific. We use a dedicated website to try and improve eventually the outcomes of these patients, but it's more than that. It's educational, and it helps everyone to level the playing field. So once you have an expert, an RB expert, and it doesn't matter if it's an ophthalmologist or pediatric oncologist or other from a high-income country, for example, from Germany or the UK, linked together with a joint discussion online, a live discussion with a colleague from a low-income country, from Africa or outside Africa, that's very powerful in order to level the playing field. So everyone talks the same language, the same terminology, etc. So this is very important for the patients, for the staff, for the centers, and eventually the ultimate goal is to improve the outcome. And I think this is a very powerful tool. So once again, thank you very much for inviting me. I'm sorry I cannot attend in person. And if you have any questions, feel free to send me an email. And you are all more than welcome to join all the RBNet MDT meetings. Thank you and